Hello, everyone. Hello and good morning. Welcome. My name is Peter Greenberger, and I am the Hill's publisher. I am delighted to welcome all of you here today to our discussion on America's opioid epidemic, lessons learned and a way forward. I'm especially excited to welcome a special guest. My mother is here. It shows what a small town this is. Over the past few years, the Hill has spent a considerable amount of time bringing to life conversations surrounding the opioid crisis. We have attempted to shine a light on the efforts to halt the march of this epidemic, and today our focus is on the role of treatment as a pathway to recovery. Academics and researchers tell us that the safest and most effective form of recovery requires a combination of medical and behavioral therapy. Yet only 20% of those battling opioid addiction are getting the treatment they need. We are going to take a look at legislation passed by Congress to fight the epidemic and ask what other policy solutions can ensure the health and well-being of our communities that are most directly impacted by this crisis. This morning, we will hear from the nation's leading policymakers, medical professionals, researchers, and patient advocates. But first, a few quick housekeeping notes. In addition to our audience here in the room, we're also live streaming on thehill.com. Please keep your phones on silent throughout the duration of the program, but we do encourage you to join the conversation on social media. You can follow us on Facebook, on Twitter, on Instagram, on LinkedIn, at The Hill Events, and we will be using the hashtag #TheHillOpioids. Finally, for those of you here in the room, you will receive an electronic survey following the event. We love your feedback. We love your input. Please tell us how we can do better. Now, it is my pleasure to introduce Dr. Nora Volkow, Director of the National Institute on Drug Abuse, for the first conversation of the program. She is joined by the Hill's Editor-at-Large, Mr. Steve Clemens. Steve?
Thank you very much, Peter. Good morning, everybody. Nora, great to meet you. So I'm going to ask you, Nora, do you think Peter Greenberger's mother is here because of him or in spite of him?
He's here because of him. And where is the mother?
No, she's great. Good to be with all of you. And Nora, thanks so much for joining us. We've got some time here. We've got an audience of people out on the front lines. I just met B.K. McDonough, who's in treatment centers out in the field. We have experts in science. And we have folks that are lay people. And I just want to have you give us a snapshot of what we, as a society, don't know about the science that you do and that you see that would be helpful us to understand the science of opioid, opioid epidemic, and how to respond to it.
Well, like anything else in science, I mean, we always, I think, have a problem in communicating the knowledge that we have in ways that are meaningful to the public in general. And I think that in the case of addiction, that's not very different. So we have been, based on the science, saying addiction is a disease, but we have failed to actually explain why is it a disease and how do our understanding of the changes in the brain that lead a person to lose control over drug intake ultimately help us understand why they do what they do. While at the same time putting this into the context of the social environmental factors that enable it to happen. So we tend to take from the perspective of science these very simplistic views, or, oh, it is a disease because my brain is not working. But then how do I then link that with the fact that social factors are so important without recognizing that there is a continuum? So if I were to choose one aspect about what is that we have failed in communicating, is how important the environment, and in particular the social environment, is for our well-being. And how when we don't have that, when we isolate ourselves, when we don't have a mission of purpose, when we don't feel that people care for us, that makes us very vulnerable to taking drugs. And in turn, those drugs affect the brain in ways that can lead us towards the path of addiction. And I think that ability to explain how sensitive we are to our environments, to our context, is something that we have not properly described.
I think part of the story, it's shocking. I guess in 2017, maybe more since, there were 70,000 deaths, and I had not realized that the that the prevalence, that the death rate was so high. And so I've gotten to know a county that's a stressed county in West Virginia, McDowell County, West Virginia, has a very, very high degree of opioid dependency and opioid fatalities. It is a socioeconomically stressed place. There are problems just in about every corner of McDowell County. And what you run into are issues of sort of moral judgment, issues of this being, people that are desperate and lost in their lives, or who are ignorant. There are all these other sort of social condemnation factors that have come with the way, in my view, McDowell County has been demeaned. What do you think we need to understand to get beyond that? Because there's an element here where those people who are suffering from this disease are being judged and tainted.
Yeah, and we were having this discussion just before, because it's not that the society is discriminating them and stigmatizing them. They incorporate that into themselves. So people, when they become addicted, basically lose a sense of value and believe in them. And that then leads them to isolate themselves. And probably the worst thing that can happen to someone, to any one of us humans, is to isolate. The isolation is probably extraordinarily aversive, very negative for the brain. So understanding that way of stigmatizing people in a community is harmful, because to start with, it's going to be making them vulnerable to addiction as well as other mental illnesses, including suicide and more, morbid obesity. There are factors that are contributing to people to try to escape. But also on the other side, once you become addicted and you want to stop taking the drugs, you go to treatment and you're isolated, your likelihood of relapse is very high. So in order to achieve recovery, we need to bring in social structures that will provide a support for that person. And again, because people like simple answers and simple solutions. And so we say, okay, yes, medicines for opioid use disorders are very effective. Actually, they are the most effective medications we have for the treatment of addiction, and equivalent to medications for other diseases. But we cannot expect a miracle. So if you have become addicted and you have, as a process of addiction, eroded your capacity to actually interact with others, it has, by repeated use of the drug, it has damaged certain aspects of the function of your brain. You cannot expect the medication to do the miracle. You have to see the medication in conjunction with an intervention that is targeting the needs of that person.
How do you do the science of that? Because what I've read, you've written about the medically assisted therapies, which you're an advocate of, need society, they need family support, and a lot of places where the prevalence of this challenge is biggest, those are the exact parts that are falling apart. So I'm interested, again, as a scientist, because there's, just to be shrewdly real about this, are there ways of changing those dimensions, or are those soft and fuzzy parts of the equation that are being invented there to kind of create excuses for not getting better?
I don't think that there are soft and smushy parts of the equation. There are integral parts of the equation. They are more complex because, the moment that you go beyond one person, the patient that is addicted, to a social system where that person is, you have the interactions of many people, and that, of course, enhances the complexity. And you're pointing your finger exactly at one of the big challenges, and that is the person that's addicted many times doesn't have that support. And it doesn't even have the support of a family. Many families, it's the disease, the only disease where you see a parent reject a child, where you can hear, I'd rather see my son or daughter dead than addicted. So it can take people to the extreme. And so how do you provide that support that's so needed for that person to recover? I says, is it insurmountable? And I said, absolutely not. We have social systems that you can create to buffer for those deficits. And that is, to me, an aspect in terms of when you're saying, as a researcher, as a scientist, what you would like to do. And the concept is, how do you evaluate the social models that can provide that support that the person needs? And one of the examples that we've known from many studies in the past, that faith communities, for example, can be very protective against taking drugs. And what does a faith community do? It gives you the sense of belonging. And so if you're not religious, there may be other communities that there's no reason why not, cannot give you that sense of belonging. And this is a message that I think is very, very important for us as a country to recognize that we are a community that if we do not provide that support, it's going to come back and bite us, because it's not just about the addiction to opioids. Now we're seeing the rise in the addiction to stimulant drugs. So we need to tackle the problem about what is it making us so vulnerable. And at the essence of that is, yes, drugs are very powerful. They change your brain. They can lead you to these compulsive behaviors. But what is making us vulnerable is like an infection. What is making you vulnerable to an infection? If your immune system is down, you're much more likely to get infected, even with the same virus.
I was reading about your past not so long ago, but nonetheless your past, where one of the things that you put on the docket was the dangers of cocaine, and that you spent years and years and years trying to convince colleagues of the dangers of cocaine. You succeeded in that, but it just is remarkable to those of us looking back that you had to do that there was actually any question in this. And so I'm interested, as you look at today at the science establishment, what are their biggest blind spots when it comes to the opioid issue? What are they getting wrong that you feel like you have insights that you need to convince them or move them or show the science that you see in incalcitrant scientific community or policy community?
I think that you already are guiding my thinking. I mean, recalcitrant, inflexible community in many ways, because we tend to actually polarize almost any argument. So with opioids, it has happened to one point that when I was a medical student, we knew that opioids were very addictive. And as a result of that, we were very reticent to provide opioids to a patient. I had a patient that has complete burn. The only thing that wasn't burned was his foot, because he had a shoe like mine. And the physician did not want to administer morphine. And I says, well, I recall saying to I was a student, I says, well, the patient is going to die, because, I mean, at that level of burn, I was in a very rural community, there was no support. And he says, it's God who determines who doesn't die, and morphine is addictive. And I recall how bad it hit me, because it is the notion of not being able to see that in certain instances, something that in others can be harmful can be life-saving, and that can bring some decrease in the suffering. So in the opioid world, we have gone from this very draconian, no, you don't touch it, to what happened at the beginning of the 2000s, where we knew better. And people say, don't worry, it's not addictive if you have pain. That's what we were taught. It's not addictive if you have pain, and don't worry, you will not overdose if you give high doses because you are tolerant. And then we started to see that people with pain became addicted, and people were overdosing that had been on this pain medication. So it is, again, that distortion that we generate and that we have, and we allow ourselves as thinking creatures to accept dogma that we knew it's incorrect because it's comfortable. And the moment that you are surrounded by people that believe what you want, and it's also, as a physician, it's a great sense of relief to be able to help someone. And if you've ever been given an opioid, you'll realize how extraordinary they are as analgesics. If you have intense pain, it's gone. And so you can understand why certain physicians would want to embrace that knowledge. And then you reject what you already know because it's in dissonance. And I think that, and now we're seeing it again, and you see patients complaining that all of a sudden they cannot get physicians that are willing to give them prescribing opioids when they need them. They are not seeking them out because of their rewarding effects. There's nothing else that helps their pain. And so, but we become, again, inflexible. And that is part of the problem that I said, that would be the message, that we need to recognize that biology, that medicine, except for when it's dead, it's black and white. But otherwise, we need to tailor, we need to personalize interventions.
The FDA at one point approved lots of drugs that were part of this addiction cycle. Now there are companies trying to create opioids that are less addictive or non-addictive or different, and the FDA and the advisory boards are turning them all down. Do you have confidence that there's a path forward? Are opioids done as a pain response, or do you think that there are pathways to kind of get the modulation right at some point?
I do think that there are pathways to get the modulation right, and I don't think opioids are gone. I mean, to start with, anesthesiologists rely enormously on opioids, and they are extraordinary. So again, it's like there are one product, in this case a medicine, can have very good properties, really life-saving properties, and also can be horrifically addicted and lead to overdose. So the issue is how to understand how to properly use it, and how to generate policy that protects the public. I think when we look at the opioid epidemic, of course, we say, okay, we overprescribe opioid medications. But there were multiple layers that led us to overprescribe opioid medications. And one of them was we created a structural system that was promoting it. You could prescribe 1 month of medications for someone with moderate pain that needed it for 3 days, and the insurance will pay. So we had created that system. So it was the educational system, the insurance systems, and then some very aggressive practices from pharmaceutical industry that we allowed them to do. So it's not like they were outside of a context or a culture. So to me, we need to be honest with ourselves, because if we just want to be, okay, and non-transparent, if we're not transparent, we won't be able to avoid falling into the same mistakes. And that's why it's not that I'm here to, I like to point fingers, not at all. I think that a lot of people had good intentions and without proper knowledge, and there was no follow-up, and there were not way to evaluate the consequences, and then we end up where we are.
Do we have the resources to deal with this at the level we need? We have 2 members of Congress, a Republican and Democrat, that will be up here shortly. I always wonder about the literacy of members of Congress on these issues, and particularly in areas of mental health and looking at addiction and how you deal with this as a disease as opposed to a moral judgment. I'm interested because you interact with these folks, and in part you're funded by these folks. Do you think we have what we need to deal with the response?
I definitely interact with them, and what I can tell you is that as part of the opioid crisis, there has been for the first time a very significant increase in the resources that we have to advance the science of addiction, and which has always been there, but the opioid crisis has brought it to the fore. Now, the level of understanding, of course, varies enormously, but I can tell you that it has been some of the congressmen that had stood up and with courage before anyone was paying attention. Hal Rogers is a perfect example that stood up and says, and he's come from Kentucky, and he was seeing the consequences in his constituents, and he stood up and generated this movement on the Prescription Summit that now serves as an example about how to bring together academicians, lawyers, industry in ways that is not about bickering about one another, but to try to come up with a common solution and to work together. So I mean, it varies a lot, but I think that the tragedy of what we're living has brought us together in ways that it hadn't happened for addiction in the past.
What drove you to become so interested in addiction?
Well, I think that, again, when we make these explanations ourselves, what is it that drives us to what we end up doing? And in my case, I think that there's more than one answer. And one of them is I've always been fascinated by the brain. I mean, to me, it's the most extraordinary thing. And of everything, what is it that makes us human? So I wanted to understand why is it that we feel? How is it that we form strong relationships? Why do we need to be with one another? Why are social interactions so important? And medicine was a great way for me to do that, so I enter it there. Now, with respect to medicine, I also have in my family a history of addiction on my mother's side. Her father, my grandfather, was an alcoholic, and her brother, my favorite uncle, was an alcoholic. And to me, first of all, I didn't know my grandfather was an alcoholic, nor did I know that he committed suicide because of it until very late when my mother herself was dying. So that notion that it was so stigmatized that my mother couldn't even tell me about it when she knew that I was fighting for it. And while growing up, I loved my uncle, generous man, charismatic, incredible person. And yet nobody spoke of him, and they said they had a dark side to him, and there was this shame in the family. We couldn't speak about it. So that notion of the inability to see that this person is a whole person, and yet there's something that leads him or her to change their behavior. That, right, to me, was what actually, how can we help that individual? And in medical school, I mean, people that were addicted to drugs were completely ignored. In psychiatry, which when I went to the residency, I have a patient that was depressed with alcoholism. And the staff attending will say, Nora, don't worry about the alcoholism, treat the depression, and when he's out, he will deal with the alcoholism. Well, if you don't deal with the alcoholism, the patient will not be able to resolve their depression. And that's dissonance. And then the concept that we were taking people addicted and putting them in prison and jail, antithetical to what you do with someone suffering from a disease. All of that is what led me to do what I do.
Well, in reading, I'm going to share a little bit. I mean, you come from a famous family of shock. So your great-grandfather was Leon Trotsky, your grandfather, his son, this issue. So you had people in your family just, and it occurred to me in visiting Baltimore the other day to a district right next to another district where there's a 20-year difference in life expectancy. And so when you look at dependency, addiction, everyone has a kind of family situation a little bit like you came in perhaps a less with a less famous grandfather, great-grandfather, and I'm interested in the fact that something you saw an insight into in your own family with people there is something that might help those folks in Baltimore or any district that is suffering from this kind of thing. And I'm just wondering what lessons we can drive. And I'm just wondering if it is the issue of embracing people, or whether part of it is medicine and part of it I think is social embrace, right?
Totally, and I think that that's what I was going to actually mention. It's the social embrace, and I've been basically inspired by people that have stood up and spoken about addiction themselves with an enormous amount of courage in an environment that was unclear that it will be acceptable, and that has inspired me too. So I would not for many years speak about my own family history of addiction until I saw others do it, and that basically made me aware that having the courage to speak up is in many ways fundamental to start to break the stigma and the silence, because if we don't speak about it, it's like it doesn't exist, so nobody's accountable.
So is this going to be a good story? I don't want to go to all of you in just a moment for questions, but I noticed in France that France has made it much easier to use medically assisted therapies, if I'm using the correct term, to respond to opioids. Someone I know, Lena Wen, when she was head of the Baltimore Health Commission, was someone who wrote a blanket prescription for essentially everyone who suffered with these issues and kind of approached that in kind of a complete open way. And when you look at France, there was a 79% decline in opioid deaths, right? So is this eventually going to be a good story in America?
I think that France puts a beautiful example about the notion that if you are able to provide treatment with no judgment and available and accessible and sustained, then you can dramatically reduce overdoses. I mean, here we have it. I mean, we need to learn from history, and you have a perfect example. And I like to point on how the success that France had in reversing the overdoses by that relatively straightforward intervention. I mean, it's obviously more complex, but provide a treatment. I mean, we have a healthcare system that is amazing. So why can't we not provide these treatments?
Is there anything you would move the needle on in terms of in the field of treatment? I'm about to go to BK McDonough. BK, where are you? Just hold on right there. I'm going to give her the first question. That can help us understand what's going on in the front line. So I know you're a scientist. I know you're developing therapies. You're looking. I want you to talk to the frontline people and hear, have that exchange for a moment. What can we do to kind of improve the triangle of support, if you will, from those that are dealing with this in the front line?
Well, one of the aspects that you learn by making mistakes, and I came to realize that for many years, I basically felt that through the science and through my own experiences, I have a sense about what addiction was. And then I realized that is very simplistic, and how important it is to bring the patient voices, the families, into actually being voices in what should be priorities on our scientific endeavors. So we think, I'm the physician, I know what's best for the patient. It's not. The patient knows what they need. So being able to bring the patients forward has been something that I learned later that I should have, but I learned it. So
I wanted to, let's bring the mic to BK. BK, I'm going to give you an opportunity for a question or comment, because I want to include the view of those folks that are running centers that are out there dealing with people out there, what this room should know about that experience and challenge.
Hi, everyone. My name is BK McDonough with Care and Treatment Centers, and thank you so much for putting this on, and it's great to see you again, Dr. Volkow. We're very fortunate at Care and Treatment Centers to actually do some work with NIDA and have some collaboration and some research. There are a number of challenges in bringing the family members, and I think you hit it right on the head there, Steve, that the ones that are closest to us are the ones that are the most damaged in the process of addiction. It is incredibly important to have those family members be present and to also learn. It's not just about educating the legislators about policy as far as addiction goes and substance use disorders, but educating the family members as well. I think family members really struggle to see sometimes their own need for recovery, their own individual need for their recovery in this disease. And it's just, without that, we have a treatment center where you might take a tree that is dying in the soil here and bring it to a place where it gets all the nutrients and the light and the water that it needs. But if it goes back into the same soil, and this is where the social supports are so important, and those recovery supports and that sense of community, if you put it back into that very same soil, what's going to change? So taking a look at the longer term needs and really looking at addiction as a chronic illness.
How many years have you been at this?
It feels like a lifetime. I've been in the field for.
Optimistic?
You know what? I'm surrounded by miracles every day.
Oh, interesting.
I am. And it's not easy. But the solutions are there. They say in recovery it's simple, but it's not easy.
Thank you. Thank you for sharing that. Other question? Yes, right here. We'll throw the mic over to you. We have lots of folks watching online. And tell us who you are.
Sure. Christine Saba, I'm a pediatrician here in Rockville, Maryland. Thank you so much for putting this on. I agree we need to focus on the opioid abuse that's going on. My concern on the forefront is the amount of anxiety and depression I'm seeing in the adolescents that are coming through,
Right.
And the substance use of marijuana and these dispensaries that are opening up. And that leads to my concern about benzodiazepine use. So I think it's addiction, it's a disease. And my concern is, certainly we need to deal with the opioid epidemic, but let's not keep our eyes closed to the other things that are coming up our path, because we're so focused on this. So I think just sort of broadening what we're dealing with. But
Nora,
thank you very
reactions.
much.
We'll give you the last word.
Yeah, no, I completely agree. And that's why I say we need to face the question, what is making us so very vulnerable? That because if it's not opioids, it's going to be stimulants. And if it's not, we're also facing an increase in the use of marijuana and people becoming addicted to it. And these are not problems that we can just solve one at a time. My perspective is, how do we provide a resilience to people so that they don't get into taking drugs and then becoming addicted. I do believe that at the essence, we have a very powerful tool in our hands. One of them is, of course, science helps us, but if science is not utilized, then it serves no purpose. And that we need to focus too in models that can provide a social support system that we require to provide resilience, prevent addiction, and for those that are addiction, allow them to recover.
I just want to say thank you for your scientific mind and your passion in this issue. Nora Volkow, Director,
Thanks.
National Institute of Drug Abuse.
Steve, thanks a lot. Thanks
Thank
very
you.
much. Thanks.
Please welcome Congressman Paul Tonko from New York. The Congressman has sponsored key pieces of legislation to combat the opioid crisis, including the Addiction Treatment Access Improvement Act. Joining him on stage is again the Hill's editor-at-large, Steve Clemens.
Your ties or jackets, so you thought I might be a different guy. How are you, sir? Good to see you. Great to
be
have you
with
with
you.
us today. I don't know if you heard any of our conversation there, but it's pretty amazing. I think we're very
didn't.
lucky
I
to have as sharp a scientist and as passionate an advocate. You are also an advocate of work, and look, I don't want to pre-frame this, but I know a lot of folks in Congress, and you're one of the ones obsessed with this issue of opioid addiction, mental health, and you are rare because there are not a lot of you up there that have these obsessions, and I'd be interested in how you became the way you are.
Well, I think a lot of it was by personal stories that people exchange with you, but in some cases, individuals that I knew as neighbors and friends who had succumbed to the illness. And so I think it becomes very important. And when you look at the data, those data are compelling. They tell us that we do have a crisis at our hands, and we have an epidemic. And if we're going to utilize those labelings, let's act accordingly, and let's respond in crisis proportion. So I think it's important for us to look at that three-pronged approach, Steve, that includes prevention, includes treatment, and includes recovery. And there needs to be an acknowledgement by policymakers such as myself that for many, this will be a chronic situation. It will be a lifetime of treatment in order for them to address the illness that impacts them. And when we document those numbers, I think 2016 or 17 statistics are the most readily all intact. It showed that we may have plateaued at about 70,000, but then some indications that we may be rising again. And so that should behoove all of us to put our best foot forward.
What does the demography of that look like? You know, I was again in a just mentioning that I've been both disturbed and trying to understand why you can have within one metropolitan region like Baltimore such incredible difference in life expectancy by zip code. And you know, you look at the zip code challenge, which you know determines now so much. I'm just interested in what you've seen in New York. What's the demographic?
Well, the demographics will show that every age group is affected, every background and economic strata. But there are some clusters by communities, and who knows why that may be taking hold. But I think that when we do look at appropriations measures like that our late friend Elijah Cummings had done with Senator Warren, we need to not only pronounce the appropriations level at a level that is going to conquer this epidemic at $100 billion, but then $100 billion, but then also to put together a focus where there's more impact for those hard-pressed areas. We've identified those, and I think that we should structure it so that more money goes into those communities.
So you've been part of two big acts that have passed, the Comprehensive Addiction and Recovery Act and the Support for Patients and Communities Act. Is the administration, the Trump administration, friend or foe in this process?
Well, you know, we've written the president, we've talked to him on the House floor when we had the State of Union message, and I would like to see a more aggressive response.
What would that look like?
I think it should be, it's first focusing on the need to continue prevention, making certain that there's not this rollback or cut to the substance abuse prevention and treatment block grants for communities or drug-free communities activities. I've seen success stories in communities in my district, specifically I could name Troy and Niskuna, New York, as great communities that have put together drug-free communities activity. Those dollars shouldn't be rolled back as the president has proposed. So
explain this, and pretend we don't know about all of the acronyms, and you know we have lay people watching online right now. What is the impact of Medicaid block grants, of what they're doing to move to a block grant format? Well, how do our friends that are in the room that are working in the front lines of community, we have drug companies here, how is that world impacted by that? Or are we inventing drama that doesn't exist?
No, we're not inventing drama. It's very important to continue these block grants because on average, I think it's about 70% of the activity that is generated at the local level is driven by those federal funds. For many states, that is 100% of their prevention activity. So if we mess with that number, we may be wiping out their whole process. I think that's important to hold in mind. And then again,
do your GOP colleagues and friends across the aisle understand that as well?
There's bipartisan support for these legislative items. I think that we need more robust advocacy from my colleagues, but it is a bipartisan support thing because, again, the human stories are what drive this, and the emotional impact and the awareness that we have a drug crisis, an opioid epidemic in our hands, should move us to the appropriate policy action and resource advocacy.
We have some folks in the audience from the National Council on Behavioral Health, dealing with mental health, and I'm a big fan of that organization. And the mental health picture is another part of this puzzle piece of how do you get, deal with the health of a community, move towards more healthy embrace of some of these issues. And that's another big area that you're concerned about, which
Right.
almost no one wants to touch.
Well,
I just went, Roy Blunt and Debbie Stabenow were, at least in the Senate side, I know you may have been the House partners, began moving forward more centers to deal with mental health. I think it was as they both described it, a toe in the door. And what's the state of support and federal partnership on mental health support in the country?
Well, having the benefit of working with mental health policy when I was in the New York State Legislature, we were able to champion the first mental health parity bill in the country, which required that if you're going to offer insurance in New York, the mental health component has to be on par with the general health component. That then was followed by the federal legislation, and now some other states have picked up on that activity. I think that in and of itself began to address the stigma that is associated with the mental health formulation, and also drew an awareness that there's this overlap with addiction, suicide prevention, and mental health policy. I think that all of that needs to be understood to be the kind of wraparound that we need so that it's inclusive in responding to the needs of those who may struggle with the illness of addiction. Much of it may be linked to mental illness or mental health disorders. So I think that it's important for us to continue to monitor the effects of and the inclusion of,
Right.
of mental health parity legislation. We don't want it to just be a buzzword. We want to make certain that we truly are weaving into budgeting bills or general policy in a way that recognizes that that concept needs to be fully ingrained into the operations of the effective agencies.
Did you watch the debate last night?
I saw parts of it,
You were lucky.
but I didn't. But I saw only
I don't mean
half
to
of
be
it.
trite, but it was terrible. I guess my question is, in the healthcare overall, is the number one issue people have anxiety about. And what's interesting, unless I'm mistaken, I'm always mistaken, there's been so little discussion of these issues as part of the healthcare debate, right? We talk about healthcare in this kind of big, generic, blue label way, and Medicare for all, Medicare, Joe Manchin
Pre-existing
tells me we can't even
conditions.
afford Medicare for some. But when it comes to something as endemic and big as opioid addiction and all of the factors that contribute to that, mental health questions, I haven't heard from any of the leading Democratic contenders anything on those fronts. And I'm just interested in what you think about that.
Well, I think it's tragic that we're not talking about this in the context of a presidential campaign, either camp, either side. And I think, again, there needs to be an acknowledgement that if we're going to see this as a crisis, we need to respond accordingly. And it begins with treatment. We still have 20% on average getting treated in that moment of clarity. There needs to be treatment on demand available for 100% of that addiction community.
So explain that treatment on demand piece of this, because I think a lot of people may not know this is another thing you're advocating for, which is to get this
Sure.
waiver. Explain this waiver issue.
Well, there's service providers that,
Right.
that are required. What we did in the recent past, was to improve that by lifting the cap that was artificially imposed, or
Explain the cap.
cap on medical, the MDs in
Right.
terms of 100 patients that could be treated with the medication-assisted
Right.
treatment formula. We raised that to 275 and added disciplines, Steve, like physician's assistants and nurse practitioners. So that began to grow the service community and hopefully the service response, so that those numbers of 20% would be vastly improved. But beyond that, we need to make certain that some of the burdens that rest in the way of getting treatment to people be taken out of the format. Such as this mainstreaming addiction treatment bill, which would take away an outdated requirement, a waiver that you go for this training at DEA. France, for instance, had such a requirement, and as they removed it, there was, I think, an improvement of 76% in terms of treatment.
79 technically.
Is it?
Yeah, I just did my research, so it's
Oh,
79.
good for you.
Yeah.
Good for you. We'll take a higher number anytime.
Showing off, yeah.
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 But,
Yeah.
I think any of these artificial barriers that stand in the way of treatment need to be taken away.
Right.
Is why focus on one particular treatment activity when we can get treatment to those out there with the community that has been adequately trained, licensed, experienced. We should enable them to provide services in this whole aura of treatment shortage. When I meet with the addiction community, the first thing individuals will bring to my attention is the inability to secure services in that moment of clarity. And I think that is a totally unacceptable measurement. It's an outcome that is regrettable. If we had that going on with some of the more traditional medical cases, diabetes, if we did not provide insulin for 80% of the diabetic community, there would be outrage. There would be, screaming at the policy makers. I think what we need here is to acknowledge that we can help, we can remove burdens, we can make access to treatment more available, and that ought to be our given goal.
Paul, the other dimension of this, and I don't know how I'm going to get into it, but I'm just going to do it, that I've been very impressed with my research and whatnot with Nora Volkow, and we just had a conversation
She's an
here.
impressive leader, and we're lucky to have her.
This notion of social embrace, it sounds like it makes sense, but it just sounds so unreal to me, because another area the Hill has been exploring is sort of the second chance economy, giving people another chance to work. Work is part of a lot of folks' identity. And if you have been a drug user, if you have been judged in some way in connection to addiction, if you have mental health issues, if you've been incarcerated for anything, you've got a knock on your resume, you've got a knock on your profile that makes very risk-averse human resource departments unwilling to hire. And I'm interested in that social equation, because social embrace ought to somehow find a way to give people another chance, and maybe even another chance. And do you look at that in the same way I do, of like connecting the economic question with the challenge of helping people through recovery?
Absolutely.
Is that a fair question, folks? Yeah. Okay. Good.
Absolutely. I think the socialization of it all, the recognition of addiction as an illness, looking to the research that has already been done that suggests that there's weaknesses in certain lobes of the brain. This ought to bring us, as a sophisticated society, to the realization that people are recognizing their illness, they're getting treatment, and there ought to be hope provided in the equation.
So
hope is incredible.
should there be something done on that? A buddy of mine, Jim McKelvey, who co-founded Square, you guys, some may use Square on your phones, he found that people he was training to code that had some speed bump in their lives, had got incarcerated, weren't getting hired. So he was sort of a celebrity. He called CEOs of companies and said, your HR departments are not hiring highly talented people that I've trained. And he turned their lives around and be getting them hired. And I'm just wondering, do we need, as part of the issue of responding to those, particularly today we're discussing those that have suffered with opioid addiction, do we need Paul Tonko? Do we need some celebrity CEO? Do we need someone else to begin calling folks and say, hey, take a chance on these people? Because if you don't do that, if there's not a proactive step, I'm just wondering, are we just kind of, noting something and just letting it float by?
Yeah, no, I think what you're calling for here is an acknowledgement of rehabilitating the individual. And what I see happening in many of these programs is a structured individual that is much more sound, simply because of the programming efforts that were made. And, we should all have that kind of structure in our lives as those so-called normal that are readily available for the workforce.
Before I go to the audience and take some questions, what are the 2 or 3 most important things you want the administration to do or acknowledge in making this a better
Well, I want them
picture?
to take strict attention to the fact that the Energy and Commerce Committee this week will be reviewing 2 of our bills that I think are important. The MAT bill, the Mainstreaming Addiction Treatment Bill, which I think goes a long way towards releasing talent and allowing it to go to work. And then our reentry bill for those who are incarcerated, which is many times the outcome.
So
for
both
our
of
loved
those
ones.
bills are in committee this week?
Right.
Being marked up?
Right. So what we're having a hearing.
Oh,
on
hearing,
it.
okay.
So basically, with the Medicaid reentry bill, many of our loved ones enter into that sphere of incarceration. It's akin to the illness. For those who are incarcerated, it's important to note that they're at risk when they're released, perhaps because of the physiological adjustment that comes. But there's a 129% greater chance that you will die of overdose within 15 days of release. Of the nearly 5,000 jails in the country, about 44 have active programs. So it's regrettable. What we need to do, I believe, is provide for a 30-day notice before release so that Medicaid-assisted treatment can begin, that they can be tethered to programming, and that we can save lives and address those lives with dignity.
Do you have Republican allies?
We have a bipartisan bill that has, I think, over 100 sponsors now.
And so allies on the committee?
Yes.
Allies in the administration?
We'll see. I don't know.
Allies in the Senate? Republican?
Yes, we've been talking to both sides of the Senate.
So you've got, better chances than most.
Well, we would hope. I would hope that everybody in this decision-making process, from executive branch and legislative, would be supportive of common sense legislation that allows people to have a sense of hope and have treatment made available, and to, again, address these lives as lives that are severely impacted by a very difficult disease.
One last short question. Coronavirus, another public health abyss that we may be looking at. Given your interest in public health, what are the things you want your colleagues to pay attention to right away?
Well, I think obviously we need to do the research that will develop the vaccine that will get us to a response which could grow into...
Well, that's happening. I mean, I think one of the questions is whether you put money into scaling that fast with government support, right?
I think scaling it as quickly as we can is important.
Let me go to the audience.
Sure.
Questions, comments?
Good morning,
reactions?
everybody.
Good morning. Right in the very back. Yes, sir.
Thanks.
You
Hi.
are.
I'm Salman Rohani. I'm with the Pew Charitable Trust Substance Use Prevention and Treatment Initiative.
And thank you for what you do. I know about it. I was reading a report you guys did, so thank you.
Thank you. I don't know if it was me, but
You should take credit.
there's many smart people on our team.
Yeah.
So part of our work is going into state and working with state governments to understand what they're spending their block grant funding on. And a common anxiety we hear is, this funding is great, but it's going away in 2 years, and that anxiety kind of trickles down to the community level. So we advise frequently on what programs to make more sustainable through Medicaid funding or other things. Has there been guidance from Congress or anyone who's distributing those funds on which types of programs should be made more sustainable in the long term?
Well, let me begin with the whole block grant issue. I think it's vulgar that we would play with those funds, especially because of the audience we're attempting to serve. And as I made mention, it is, for some states, far too many, 100% of the work that they do. So to mess with those funds is to mess with certainty and predictability, which then destroys the whole mechanism of providing hope for individuals. In terms of waivers and allowing for other sorts of programs, I don't know if you're going to get those directions, but certainly the state initiatives coming toward the federal government, requesting for waivers, as my home state of New York has done with the Medicaid program for incarcerated individuals. I leave it to states to be very aggressive, but I would encourage states to really get on our case to expand the dollars to at least by $500 million for the block grant situation.
Right here.
Hi, I'm Liz Cairns. I'm with Center on Addiction, Partnership for Drug-Free Kids. Thanks for being here. Thanks for championing this cause. You mentioned a couple of bills that are coming through committee. I wanted to also call out, speaking to the support for families, family services, community of embrace, there's a bill coming through committee, we just got word, called the Family Support Services Act, and just wanted to bring that to everyone's attention.
Who's pushing
Thank
it?
you. Senator Gillibrand.
Okay, good to know that. Thank you very much.
Thank you.
Quick comments. I'll give you the last word, Congressman.
Well, I think that anything we can do to reinforce, because these illnesses are oftentimes impacting an entire family, I think it's important for us to have the resources so that people can cope as they go forward. I've talked to a number of families that have acknowledged in very painful measure what it means to their whole quality of life, to their stability. The impacts are severe. Whatever we can do to make certain that it's an inclusive approach, I want to do. But it's time for this country to recognize mental health, addiction, and suicide prevention as dynamics that are very real, and they need the reinforcement of policy, appropriate policy, and resource advocacy.
Well, Congressman, I want to thank you on behalf of all of us. I mean, I think we're doing this because this is an important issue, and as I started out, I feel like it's one that comes out every once in a while, people line up, but I look forward to you mainstreaming this with many more of your colleagues and making it an everyday concern. So
well, thank you, Steve. I think it also is good for, you're most welcome, it's very good for the media and the outside world to become very, very much into the advocacy. And so I appreciate your involvement and the Hill involvement to, again, throw another pebble onto the pond so that the ripple effects of sound thinking, of compassion, and science-based and evidence-based opportunities are embraced wholeheartedly. So to all of you here in the crowd, thank you for being those agents of hope.
Ladies and gentlemen, Congressman Paul Tonko, thank you so much.
Thank you, Chief. Good to see you.
Please welcome Sean Thaxter, CEO of Indivior, for underwriter remarks.
Good morning, everybody, and thank you for coming here today. My name is Sean Thaxter, and I'm the Chief Executive Officer of Indivior, and I'd like to say what a tremendous privilege it is to be able to come and participate in the conversation today about the way forwards. Indivior is a global pharmaceutical company committed to changing patients' lives by developing medicines to treat addiction and its co-occurring disorders. We are encouraged that around the world, the opioid use disorder is increasingly being recognized as a treatable disease and not a moral failing. Significant progress has been made over the past 2 decades in understanding the patient journey towards recovery, increasing scientific understanding of addiction as a disease and advancing innovation in evidence-based treatment. New public policies have helped build the national, state, and local infrastructure critical to helping patients and caregivers access resources, funding, and evidence-based programmatic support in communities across America. And in January 2020, the Substance Abuse and Mental Health Services Administration released the 2018 National Survey on Drug Use and Health for Key Substance Use and Mental Health Indicators in the United States. The 2018 data reported decreases in both the percentage of people who reported opioid misuse in the past year and, for the first time in over a decade, a decline in drug overdose deaths. However, the truth is that the journey of recovery for millions of patients is not over. But the tragedy is that for the vast majority, it's not even begun. The patient need continues to be urgent, as evidenced by new data from recently released reports from the White House Office of National Drug Control Policy, the National Drug Control Strategy, and the accompanying National Treatment Plan for Substance Use Disorder. The data highlight that 21.2 million Americans need treatment for substance misuse disorder. However, only 3.7 million receive any kind of treatment. This means that 4 out of every 5 people suffering from addiction, our family, our friends, our neighbors, remain underdiagnosed, undertreated, and undersupported, leaving them feeling isolated, marginalized, lonely, and in despair. The National Treatment Plan for Substance Use Disorder frames multiple factors which contribute to this treatment gap between those needing treatment and those receiving it. People in urgent need of treatment are often unaware of their treatment options. They have limited access to treatment with counseling, or they simply do not seek it out because they're afraid of being stigmatized. Societally, we still have more work to do to eliminate the ignorance, the apathy, and the prejudice that creates stigma that is a reality for so many people struggling with this disease. We must deepen the understanding of opioid use disorder as a chronic brain disease and continue to build awareness that this disease can and must be treated, much like other chronic diseases like diabetes and heart disease. One of the most significant contributions to furthering our understanding of the science of addiction was led by the research of our keynote speaker today, Dr. Nora Volkow of the National Institute on Drug Abuse. Due to NIDA's groundbreaking research, we can now see how addiction affects both brain structure and function, trapping people in a cycle of opioid use, withdrawals, and cravings, all of which reduce their ability to control their own substance misuse. This research has been critical in defining addiction as a disease, advancing our understanding of how the disease affects the brain and furthering the development of evidence-based treatment that can help patients move towards long-term recovery. Patient voices are vital in helping raise awareness as a disease. By speaking out, patients help to destigmatize the disease of addiction and other mental health illness and provide hope and help to others. Of course, we're all individuals and every patient journey is different, and we're fortunate to have the opportunity to hear a personal experience from one of our panelists today. Advances in federal and state public policy are also acting as a catalyst, creating a fundamental mindset shift that continues to move addiction towards mainstream medical practice, while putting resources in place to help more people, caregivers, and their communities access the supports they need to move towards long-term recovery. For example, new laws like the Comprehensive Addiction and Recovery Act and the Support for Patients and Communities Act have provided billions in funding for new prevention treatment programs and treatment support. These significant federal investments are making a difference as more of these resources move to the front lines. We are seeing evidence of this in the number of healthcare providers who have become waivered to treat. They increased by a record amount in 2019. This funding also recognizes the value of prevention programs and further investment in expanded research into opioids and recovery. We are joined today by 2 members of Congress, Representative Paul Tonko from New York and Representative David Joyce from Ohio, who are both tireless champions for the recovery community and patients. Both members have been strong advocates, introducing legislation, co-chairing the Congressional Addiction Treatment and Recovery Caucus, and advocating for funding to help combat the opioid crisis. We appreciate their tireless work advocating for laws and regulation that impact the availability and access to effective treatment, including counseling, for patients, which plays a critical role in helping to reduce the number of people suffering from addiction. As stakeholders, we must all work together to destigmatize those seeking treatment, to educate about available treatment options, and to reduce barriers to access medications to treat opioid use disorder, including counseling, to help move people on the path to long-term recovery. We know too much about this disease for so many people to struggle continuously. So thank you very much for this opportunity to engage with you today and to learn from this distinguished panel whose dedication and leadership continues to make a meaningful difference in changing outcomes for patients. Thank you.
Thank you, Sean. Please bear with us as we undergo some renovations. Now, please welcome Christina Andrews, Associate Professor of the College of Social Work at the University of South Carolina, Dr. Annika Alvanzo, Regional Director at the American Society of Addiction Medicine and Assistant Professor of Medicine and Medical Director at Johns Hopkins University School of Medicine, Monique Tula, the Executive Director of the Harm Reduction Coalition, Walter Ginter, Founding Project Director of Medication-Assisted Recovery Support with the Hill's Julia Manchester.
Hey everyone, thank you so much for coming out for this very important discussion, and thank you to our panelists for agreeing to spend some time to chat with us about this topic. So just as an icebreaker to introduce you all to the audience and to me, if we could just go down the line and talk about your backgrounds and how you got involved in this field. Christine, I'll start with you.
Sure. I began my career in Philadelphia working with a nonprofit management consulting agency that worked a lot with a range of health and human services organizations, homeless service providers, mental health treatment programs, primary care, community-based settings. And one of the things that really struck me through doing that work was just how significant the challenges of addiction were in so many of these settings. And it really drove me to want to focus more on trying to address some of those challenges. And I decided to do that through research. And so went on to get my PhD at the University of Chicago, focusing on addiction with a special focus on opioid use disorder treatment and understanding how we can use financing, particularly through some of our public insurance programs like Medicaid, to really improve access to those services.
Absolutely. Anika?
So I'm an internal medicine trained addiction medicine specialist. So I actually did a primary care residency. Thought I was going to be a primary care physician, but I had an interest in violence against women. And one of my attending physicians introduced me to a researcher who was doing research in the OBGYN clinics. She was doing addiction related research. And she allowed me to add a violence measure to her survey battery. And it was in analyzing that data that I saw the link between violence against women and addiction, and that's actually how I got interested in addiction.
Absolutely. Monique?
Well, I come from a family of people who use drugs, people who have engaged in sex work for a living, and I began this work actually in a small syringe service program in Western Massachusetts, and eventually began managing one and moved into this role about 3 years ago. But harm reduction actually gave me language and a way of life to actually deal with some of the traumas that I had experienced and many people in my family had experienced as a result of substance use.
Absolutely, and Walter wraps up.
Okay, first of all, I'm a patient. I've been, reverb there. I'm a patient. I've been a patient on medication-assisted treatment for almost 40 years. About 20 years ago, I first realized that I actually was advocating for medication-assisted treatment. And one day I was interviewing the head of the provider organization, And what he said to me was, I asked him, I said, how come the programs do such a terrible job of educating patients about addiction being a brain disorder and not just bad behavior? And he said to me, Walter, suppose when you were in my program, I told you that you had a chronic disease and you might be on this medication the rest of your life, what would you have said? And that was my aha moment. If you're really lucky in life, you have an aha moment. Because I realized that what I would have said was, you bloodsuckers are just trying to squeeze the last dollar out of me. And on that, I realized for the first time that there's some things that a patient can say to another patient better than anybody else. And from that moment on, I dedicated myself to talking to other patients and teaching them about addiction, and that it wasn't just bad behavior.
You know, when I'm not working with the wonderful events team here, I cover campaigns for the Hill, and I recently got back from New Hampshire where the opioid crisis is very prevalent. I talked to a number of voters who are really frustrated with the progress that government and, has made so far on the issue. So I just wanted to get all of your takes on, how far are we away from a treatment and what progress has been made? What can we expect to see in the next 10 to 20 years, for example? Walter, I'll start with you on that one.
Well, everybody understands that addiction, opiate addiction especially, is a biopsychosocial disease. And I think that expanding treatment is noble, and it's something that really has to be done. But there's three things going on in addiction, opiate addiction. It's biopsychosocial. And the medication treats the biology extremely effectively. But, and unfortunately, the counseling we're giving out is not adequate. The people doing the counseling tend to be more bookkeepers than counselors. And finally, we're not really giving people the social support they need. Until we accept the fact that we really have to do all three at the same time, we're not going to be treating addiction. But this is a good start, at least getting the medication out.
Right, and Anika, if you could talk about the work being done in terms of next generation prescription painkillers, there's hopes that there will be less addictive and in turn you will have yet less opioid use disease. How far are we away from those kinds of treatments?
Yeah, so I'm not a pain medicine specialist, so I'm not as abreast in terms of the development of medications for managing pain. What I will say is that we are seeing advances in terms of development of medications for managing addiction and treating addiction, in terms of different formulations that may result in less risk of diversion and things like that. And so I think we have a ways to go in that. We have very effective medications for opiate use disorder, but we know that many patients have multiple substance use disorders, and we have less effective medications we don't have any effective medications for stimulant disorders. And so I think when we talk about medication development, we really should look at medication development for treatment of all types of substance use disorders.
Right. And Monique, in terms of how informed the general public is about opioid use as a disease, how much do you think they're informed about this, and what could be done to maybe make them more informed, maybe on the part of the media and the government?
Well, what we're hearing about in the media is the opioid crisis, right? And I tend to disagree with folks who characterize substance use or abuse as an illness. I believe it's a symptom of a much deeper illness. And there's significant gaps in the way we treat substance use issues. The people who have the answers, who have the solutions, are the most at risk and the least likely to be consulted. So as advocates and so-called experts, it's really our job to make sure that Congress is listening, right? So what we're looking for is a much more comprehensive infrastructure. It's not just about medication, right? It's not just about syringe service programs, although those help. It's not just about naloxone distribution, although that saves lives, right? Or testing the drug supply, which is relatively simple to do and very cheap through fentanyl test strips. But harm reduction in some ways, in the traditional sense, is a very downstream approach, and it's all we can do to keep folks healthy and safe, right? But we need upstream approaches that prevents, I mean, I heard someone talking about this earlier, I think it was the doctor who was talking about this earlier, you know, what's happening in people's lives that puts them on this path in the first place.
Right, and I just would like to pick your brain on that point, especially when it comes to the much deeper illness. Could you just elaborate on that? Do you mean in terms of, you know, mental health, or where does this, I guess, originate from?
Well, you know, I'm not a scientist, but there's an author who did a TED Talk. His name is Johann Hari. I think it was in 2015. And one of the things that he talks about is the need that humans have for bonding. He says that the opposite of addiction is not sobriety, it's actual human bonding. So I believe that. And if, you know, human beings, we're mammals. In order to thrive, we have to bond with other human beings. And if we don't have positive, healthy relationships with other human beings, then we'll bond with something that gives us anything, that gives us a little bit of joy, right? A sense of relief, no matter what the long-term outcomes may be.
Right. Christina, I'd like to get your take on the role of Medicaid and Medicare in all of this. You know, how have they been involved in, I guess, trying to combat this crisis or alleviate it and, you know, help with victims of this?
Right, absolutely. Medicaid is playing a really essential role in addressing the opioid epidemic in the United States. About 40% of all of the funding for addiction treatment in the United States now comes from Medicaid. 40% of people with opioid use disorder are covered under Medicaid. And so that, I think, is a really important thing for folks to understand, and how important that program is in being able to facilitate access to care. At the same time, insurance coverage doesn't necessarily equate with access to treatment. Right now, we have about 40% of our specialty treatment programs that offer medication for opioid use disorder. This is the evidence-based standard of care. Other things also need to come alongside medication. It is necessary but not sufficient. Can you imagine a situation where only 40% of providers who treat diabetes offer insulin? This is something that we really need to make strides on. Medicaid has done a lot in terms of increasing access to medication, but there are still gaps, particularly around managed care programs that have a lot of discretion and don't necessarily cover the same range of services and medications that a state Medicaid program, for example, would specify both in their state Medicaid plan and PDL.
Absolutely. Walter, I'd like to get your take on, really, based on your experiences, I know you're obviously involved in this field, you mentioned you were a patient, but what do you think is probably what you find to be the most effective treatment or recovery for this disease?
All right. Well, first of all, I still am a patient. All right. But for me, what we realized is that you need all three, as I said before. It's biopsychosocial. You need the medication, you need counseling, some kind of psychological counseling, but you need social support. When I first started doing this, I remember a counselor coming in, talking about secondary drug use, coming into my office and banging on the desk and said, "What kind of voodoo are you using here?" And I didn't know what she was talking about. And she said to me, "I've had this patient for 15 years and she's never gone 2 weeks in a row without a cocaine positive." And, you know, our project had nothing to do with cocaine. And so I didn't understand what they were talking about. And then I looked into it and I realized what was going on. This person had never considered themselves as a candidate for recovery. To them, methadone, which they were on, was just another drug, a substitute. So what happened was they didn't feel they were in recovery. They just felt they were taking the man's drug, the man's heroin. Once we introduced recovery and put recovery on the table, then suddenly she wanted recovery. And she wasn't addicted to cocaine, she just, used it. It didn't matter to her because she was still using methadone, which she considered a drug also. Once we took that off and made methadone into a medication, she really wanted recovery, and she stopped using cocaine. And that was the first time we discovered the result that peer services were having, not just on opiate addiction, but on addiction in general. Right. So, we think that peer services, in conjunction with all the other supports, are what's necessary for people to find sustained recovery.
Right. I'd like to put this question to all of you. What do you all think are some of the most critical challenges and barriers experienced by individuals seeking treatment in long-term recovery? If any of you have a particular take on this.
So I think there are a number of barriers. I think one, we don't have the workforce that we need.
Yeah.
So we need legislation that will support increasing the opioid workforce, or the Opioid Workforce Act. I think traditionally addiction treatment was kind of segregated from the rest of medical treatment, and so with that, there was a lack of quality and standard and performance measures, and now we're trying to mainstream addiction, so we need development of quality and quality metrics and application of those metrics. We need payers to pay for treatment, and we need elimination of some of the barriers that exist. So again, going back to some of the legislation that Representative Tonko is supporting, the Medication Expansion and Medication Access and Treatment Expansion Act, the MAID Act, which would again allow for health professional schools that are training physicians, physician assistants, and nurse practitioners to include that training in their curriculum, such that when their graduates graduate, they are already trained to recognize, identify, and treat patients with addiction. And then also the MAT Act, which would then eliminate the barrier, so reduce the need for the additional DEA waiver, and get rid of these arbitrary patient limits. So I think there's a number of things that can be done.
Right. Yeah, Christina.
Well, I think as well, coming back to the issue of availability, that is a big barrier to treatment, particularly for people in rural areas or who reside outside of some of these large urban centers. That's an issue across the board, but we had a study come out last week in Health Affairs that showed that among people who are older adults, Medicare eligible, only 20% of Americans live in a county that has a substance use disorder treatment program that offers medication and accepts their insurance. So doing a lot of work to address this issue of availability and coverage is key. And with regard to the availability of coverage, just simply having some kind of basic benefit for that medication or service typically isn't enough. We hear a lot about patients as well as providers talking about the barriers that arise as a result of utilization management policies. And those policies are important in terms of ensuring appropriate, efficient use of care. But at the same time, I think we need to think carefully about, how these prior authorizations, annual maximums, quantity limits, co-payments may inadvertently cut people off from care that's working or deny them the opportunity to get that medication to begin with, particularly when you have somebody walk in, they want to start treatment, and a provider has to say, we'd like to start you, but we've got to wait 48 hours or whatever amount of time in order to get this prior auth paperwork through. That person may walk out the door and never come back.
Right. Monique, I see you nodding your head to that.
Emphatically.
Yeah.
There's early findings of low barrier MOUD, we call it medication assisted treatment basically, is highly promising, and especially so for people who are experiencing homelessness or are otherwise other forms of instability. So the efforts that we're making, right, to expand MOUD across the healthcare system, we should also have a parallel process that includes expansion into syringe service programs. There's about 9 states right now that either are providing or preparing to provide buprenorphine on site to people who are most at risk for overdose. We should be offering MAT at homeless shelters, emergency rooms, and also correctional facilities, and as points of access for people who are otherwise disconnected from routine healthcare.
Absolutely. And I just would like the audience to know we're going to have a brief question and answer period coming up in about 2 or 3 minutes. So think of those questions if you have them. But my final question to you all is, you all work in different parts of the country. And, I just want to get your take on how your respective states and cities are trying to improve access to treatment at the local level. Walter, I'll start with you.
Well, I'm in the Bronx, in New York. If you would ask me this question a few years ago, I would have said terrible. But right now, we've really come a long way in New York. They're expanding medication-assisted treatment up in what we call the Western Tier, areas that are rural, that, we think of New York, we think of many, many treatment programs, but most of them are congregated around the New York City area.
Yeah.
Now we're starting to add programs in the Western Tier, new places are opening up. Medicaid is starting to reimburse for peer services, and so I think that there's a big change in the attitude towards even though New York had always been a very pro-medication place, it still was limited, and I think that the state agency has expanded, and they're doing a really good job at it, and I like to kind of congratulate them for that.
Fantastic. Monique.
Some of the work that's happening in San Francisco is pretty impressive. We are actually launching a program that is working with folks who are living in SROs or single room occupancies to prevent overdose among that population. But I have a mostly national perspective, and I cannot emphasize enough how important it is that the CARE Act is passed, the legislation that the late Representative Elijah Cummings and Senator Warren introduced. We're talking about $100 billion over 10 years, right? And that is the kind of money that we need if we're really going to move the needle.
Definitely. Monica.
So I practice in Baltimore, where unfortunately heroin has been endemic for years. So Baltimore City Health Department is doing a lot with respect to, one, trying to train primary care providers to be able to provide addiction treatment. So partnering them with specialty addiction treatment centers that then they can have an exchange of patients when patients aren't doing well in the primary care setting. Recognizing that not only community providers have a responsibility, but also hospitals. So they have established a level of care system for the hospitals, where hospitals get ranked based upon their response to the opioid epidemic, including whether they are initiating medications in the emergency department or during acute care admissions, and then linking people to care. Certainly expansion of Medicaid expansion and expansion of treatment availability, but even still, with all of those things, we are still seeing a rise in our overdose deaths rate in Maryland, and so we still have a ways to go.
Right, and Christina.
Right. Well, I'm in South Carolina, and we've seen a lot of important work, particularly that's been funded through both the Cures Act and the Support Act, that has brought in new federal resources to help build infrastructure to provide opioid use disorder treatment, particularly a big increase in the proportion of our treatment programs that are offering medication for the first time. We're also working to initiate buprenorphine within all of our states' emergency departments, and building those bridges between the ED and substance use disorder treatment programs to try to get as many people into care as possible. And I really respect those efforts and the work that's been done. I think one of the remaining challenges is that, as South Carolina has not done a full Medicaid expansion, there's sort of a lot of discussion about, what will happen if and when that federal funding, comes to an end, and how are we going to sustain this system that folks are trying to build there, because we're going to be dealing with this problem for a long time. It's going to be the public health challenge that is likely to define this generation.
Absolutely. And now I'd like to open up to you guys. I think we have time for 1 or 2 questions. So if anyone has any thoughts, I think we have someone up here.
Thank you. Thanks for this panel. My name is Li Yang. I've always considered the patients or the social environment A lot of time, the patients are mislabeled. Actually, the patients and they need a better living conditions. And they see the social problem, but they don't fix the problem. Instead, they bring the patient to the mental hospital or give them some drug that's not supposed to be. So I just wonder if we can advocate the government doing some better job. Government should have brain to fix the problem rather than become the brainless. Means they are not doing the job government supposed to do. They label the patient, they make the homelessness and make the financial problem for the family. And that means working opposite directions.
Absolutely, yeah. Do you all have any thoughts on this?
Well, I would say that, not specifically labeling, but I know that it's the homeless problem. It's impossible for someone to find sustained recovery if they're living on their cousin's couch. It just, it just doesn't happen.
Yeah, we have to have housing that is not contingent on abstinence. And in addition to that, people who use drugs can actually be employed. They need access to education. They need, to find some purpose and meaning in life, just like anyone.
Right.
And I think you're a great example of that.
Right? Thank you.
Yeah.
And I would also say for our patients, housing is a big barrier, and many times we have patients who are doing very well on medication, and then they are denied access to recovery housing because they are on what we know is effective treatment. So.
Yeah. Absolutely. Well, I think that's all the time we have. Thank you so much to our panel for coming out here. I know you traveled far and wide, so we appreciate it.
Please welcome Congressman David Joyce of Ohio. Ohio is one of the states hit hardest by the opioid crisis, and Congressman Joyce has worked to help communities in the state and across the country. Joining him on stage is Bob Cusack, Editor-in-Chief of The Hill.
I'm waiting for you to give me the go sign.
We didn't even have to say, please clap. Congressman, thanks for joining us this morning. I want to start with some news of the day, and obviously coronavirus is the big issue of the day. The president announced this morning that he's going to have a press conference at 6 p.m. tonight. Senator Schumer has indicated that the request should be higher. He's asking for $8.5 billion. The president has asked for $2.5 billion. You remember the Appropriations Committee? What do you think is going to happen? What is Congress going to do to deal with this possible pandemic?
Well, first off, I appreciate the fact that they're taking some responsible steps towards trying to contain and get out in front of this as best we can. And it's going to require funding, obviously. I think the $2.5 billion, it sounds maybe like not enough, but the one thing I found when I first got here, we had the Hurricane Sandy, and all of a sudden we had to give $60 billion. I'm more of a fan of incremental growth. I mean, we'll give $2.5 billion now, and I think if it's determination later that you need to get to $8 billion, that's what it's going to take. But Congress can act on its feet, and I think it's important that we act on our feet and deal with this deliberately and make sure that we take care of and address the situation as quickly and as responsibly as possible.
Do you think something could be, some type of emergency spending bill could be signed into law relatively quickly?
Yes. I mean, that's one thing. We do tend to work on deadlines pretty well.
Right. Got to set them, right?
You know, for whatever reason, we seem to have more profound thoughts on December 21st about budgeting process than we do the rest of the year.
All right.
But that's unfortunate, and you know, that's our fault. We should do better than this.
On opioids, I was looking it up, and 2 years ago to this month, you and I sat down to talk about this issue. Can you give us an update on progress made and where progress has to still be made on opioids, specifically your district? I know you're part of the task force. You're having town halls on this issue all the time.
Well, you know, 20 million people wake up every day addicted. So in this country, and you know, that cuts across every social, economic, even districts. And how I got started, for those of you who weren't here 2 years ago, you know, I haven't been a prosecutor for 25 years before I got here. We sat down, and we have a little bipartisan group of Susan Brooks, myself, Joe Kennedy, and Kathleen Rice, former prosecutor, or recovering prosecutors, as we like to call ourselves. And we first sat down trying to think where we could have the most impact. And you know, as we went around the table, there's probably 20 of us in the room. Opioids was the one common denominator to everybody's district. So we tasked ourselves with the fast. Let's go back to our districts and find out what the problems are, and two, what's working. And you know, from prosecuting the days of old, we watched whether it was cocaine, crack, meth, LSD, everything sort of worked in waves, right? You know, it came in and it worked out, and then something else became fashionable, if you will. And we sort of arrested our way out of those things. And this is something that's completely different. We noticed that it no longer is, say, like with the alcohol or the other addictions, where 28 days alone in a rehab center, and you walk out, and people can get back on their feet and usually reintegrate, and you didn't have the recidivism rates we were having as we were with opioids. And so and just last week at home, I go around to all these different community centers and the police departments and sheriff's departments and ask, you know, what's working, what hasn't worked, how can we be better, where can we push more money? And the one thing you'll notice that's a common denominator now is the fact that this is not something that's 28 days. This is maybe 9 months to 2 years. And we really need to extend our programs and help facilitate that change in actual lifestyle, because returning people to where they came without employment tends to put them right back in the situation that got us there in the first place. I tend to see this as something it didn't just happen. Like when I left to come here, and I got elected in 12, so I started to see heroin and opioids were a problem, then heroin really in 10 and moving on. But it was one of those things that I really think the opioid problem started more in the 80s and 90s, whenever we introduced those silly smiley faces as to pain management. And so we gave reimbursements to doctors and hospitals based upon people being happy. So it was a hell of a lot easier to make people happy and give them the prescription they were requesting. And I know from my times as a prosecutor, it was awfully hard to break that doctor-patient relationship, because if the doctor was really somebody dealing in this business, you know, you strip a person down, they can't wear a wire. And so you really weren't being able to break that. So what we did is start following the people after they were getting their script, even though this is an all-cash business with the doc, right? You know, we'd start following them to where they were getting it filled. And then, you know, went after the pharmacies and tried to tighten up that way and did it. But, you know, again, it's now, you know, they were still finding the opioids, and they were still finding, unfortunately, then the heroin that came into town that was even cheaper. And the bad part, well, in Ohio, we were at ground zero, the number of deaths from overdoses has come down, thank God. All these task forces are telling me meth is coming right back in its stead, and it's coming in stronger, and unfortunately as cheap as it was, as heroin was when it first got here. So, and it's also getting cut with the fentanyl, which is horrible. So while we've made some strides in what we're doing, I don't think we're out of the woods yet. Mm-hmm. We need to continue to fight and provide funding into those areas that work, and change the ideas that, you know, but for this addiction, these are productive members of society who are unfortunately in the grip of the devil itself.
Speaking of resources, you've introduced the COPE Act, which is looking at the co-sponsors, really conservatives and liberals on this bill. Can you tell us a little bit about the legislation and where it goes from here. Now it's at the Judiciary Committee.
Mm-hmm.
Do you think that could move sometime this year?
I hope so. I mean, the idea that we could provide Narcan, to be able to provide that for first responders and make it available. You know, and you get a lot of pushback when you say, well, you need to have it available in schools. You need to make it available to kids so they can help their parents. Just to make it available so first responders have the ability to use it and have that at the ready. And you know, one of the discussions I had last week, I mean, every thanks to the local hospital, every police department, every squad car, you know, they've got at least one in the car. The schools have now had it, and making sure that it's available and that first responders are properly trained in how to do it. And it's, you know, truly a shame that we have to teach school children how to do it or administer it to their parents or to the individual, the guardian, whoever they're with. But it's something, unfortunately, that's needed, and it's something that we're going to continue to do. And, you know, I'm not going to lie to you, there was some pushback when I first started bringing up these ideas of bringing Narcan from some folks be like, well, you know, these people have done it to themselves. I mean, you know, it's a disease. And you know, nobody asked for this disease. Unfortunately, they got the disease just like they had cancer. And we try to cure cancer, we try to prevent these things. We need to do the same thing when it comes to this type of addiction.
Have you seen improvement on specifically that attitude, the stigma of it? Because there has been a lot more education on the disease. Has that gotten better? Have you heard less of that, well, he did it to himself kind of thing?
Right. Well, you know, one of the things I give credit to Facebook. They put out this thing about Stop Opioid Silence that I partook in, as well as a lot of other members of Congress, where you talk about get on, and they did little public service announcements basically, but these PSAs were about stop the silence, share your stories, and the idea that, you know, you're not alone, and to come out of the woodwork and you don't want to admit that that's an issue, but get involved and get your communities involved, because it's something that we all have to do together to help these folks get through this and realize that, like the drug courts we have, to give you an idea, one of the great things they're doing is they're testing these individuals as they're coming out on a bi-weekly basis. So for employers, what better thing to know than that your employees being tested on a bi-weekly basis, and you're not going to have this problem because that's a concern to them, obviously. And trying to get employers and communities to understand that, you know, these are good, honest, productive citizens, but for this problem that they're going through, and working together, we can get them to that next stage and get them back to where they started from.
We're in election year, very polarizing time, and I know this issue has members that we've had at events like these. They've said, despite all that, despite the election year, the polarizing times, can you describe a little bit of how this has fostered relationships across the aisle, which is so rare nowadays?
Sure. And, with all due respect to the media, you know, if you went down into the locker room like this morning and you saw everybody working out and giving each other grief, you have no idea who's a Democrat or who's a Republican. We're all overweight, aging athletes that are trying to stay in a semblance of shape.
Never give up, right?
Quality eventually, that's our motto. And so you know, a lot of times it gets fostered that we really don't work together. But there are, as I tell folks at home, there's 435 members here who love their country and want to see the right things happen. We just might happen to see the solutions from a different lens. And so it's important. The one thing that I found in my time here in short commodity is the ability to listen. So if you listen to people and you listen to their stories or the problems that they're having at home, and then you can explain to them, well, here's some of the things that we're trying to get done with the opioid crisis. And I realize you don't like to spend money, but we're going to spend this money. And wouldn't it be better to spend this money in a targeted way that actually helps people or gets people to where they need to go? And having the buy-in, the solutions that way, I think is getting us a lot farther. And there's a lot of people who, again, no matter where you're coming from, it's happening in your district. All of us in this room probably know somebody who's been touched by it. Lost a nephew to an overdose that was fentanyl-based. My kids have lost friends, unfortunately, to overdoses. It's a sad reality that hits all 435 districts, all 50 states. And we've lost more people than we have the Vietnam War. And we need to address it, I think, in similar tactics. So you get buy-in from folks if you can at least get them to sit down and whatever the area they have some concerns and address their concerns and have them get buy-in to, like, this is a big program. It's a multi-step program, and we need to have you all in and getting it done. And I've not felt much resistance. Initially there was some, but more and more people now when they go home saying, ask your local sheriff about it, ask your local EMS people, get them aside, go up to the hospital and ask what their biggest increase in emergency room visitations are. And then all of a sudden they come back and they have changed attitude towards the need for help and the need we all need to work together to get this accomplished.
We're going to open up for questions in just a couple minutes. As far as you mentioned obstacles and pushback, have you seen better coordination between the feds and local communities and providers and the healthcare communities? Is that the reason why there has been some progress here?
Yes, and there's even been progress between the House and the Senate.
That's rare. Yeah.
Bicameral progress. No, it's one of those things where you talk about, well, we're going to pass this in the House, but that's only halfway home, right? We got to get it through the Senate. There's buy-in on both sides. There's buy-in, bicameral, bipartisan support here. And that's strong when you go back home and you talk to the hospitals and folks that saying that this is an all-in approach. We're all in D.C. We need you all in here. And, I don't come telling you what the answers are. You tell me what's working. And then we come back and work on how we can get the appropriate, let's face it, financing to those problems for you and for the longer term recovery, to the Narcan, to one of the things you want to do is someone who finally admits, it's got me, I need help. Get that person to where the help they need. You can't tell them come back in 3 weeks, because they'll probably be dead. So you need to have ways that we can bring the help to them right then and there. And getting the communities, the hospital systems, like say, providing Narcan. That wasn't necessarily heard of a few years ago, but now all of a sudden to make it available and to do the necessary training so it's available where it's critically needed, in schools, at colleges, in places where kids gather. That's an important part of the program. It's also getting people to buy into the fact that if you see people buying or gathering, give an idea, there's a local 24-hour gas station spot. And all of a sudden there'd be all these cars there at midnight. And one car would come in and they'd all meet by this one car and everybody would take off. Well, guess where the heroin just came from? So, you start to, and having people report that. The fact that there's a gathering and all of a sudden there shouldn't be a gathering necessarily at midnight, because it's not like they're gathering by the pumps. To report that stuff so that law enforcement can take it. You got to get that whole community approach to really make this work.
Got a few minutes left. We'll open up for audience questions. If you can wait for the mic and identify yourself and ask a quick question.
I'm Christopher Gable. I'm a pediatrician in Ohio, and I grew up in your district.
Oh, great.
What affects the adults affects the children even more. Neonatal abstinence syndrome is a huge issue, especially in Ohio. And
it's heartbreaking.
It's heartbreaking. And, so I wanted to hear a little bit more about your thoughts on how these kids are going to go through life, because we don't know, when they are born with this affliction, what their outcomes are like throughout their entire life. And as pediatricians, our job is to prevent this from happening. And then also, Medicaid doesn't have the payment parity of Medicare, so that reduces access. Representative Schreier will actually be submitting a bill tomorrow about Medicaid and Medicare parity. So I want to see if you could see your way to supporting that.
Well, thank you. I'm not going to tell you I know every bill that's being put forward, but I certainly appreciate the input and dutifully in the back taking notes for assistants of mine to make sure that I get a hold of that bill today and take a look at it. Our caucus generally passes bills back and forth among each other to help. As to the syndrome, I guess the most critical thing we do is stop the abuse of the people before they get to that point of being addicted and having babies that are born with it. That, going down to the neonatal care at UH and seeing what's taking place, man, I don't know a way to stop that. I sure like to find a way, because it's a shame what's happening. And unfortunately, these are sort of like, I hate to admit it, but almost test cases with these babies now, because we'll see how it carries out. Hopefully it doesn't lead to them becoming addicts or having these problems, and rely on folks like yourself. I mean, I don't I'm 25 years in law enforcement. I'm pretty good in crime scenes and courtroom procedure, but I rely on folks like you to tell me what's working and what's not working. And so that's why you got to grab, you don't live in the district anymore, but feel free to reach out in whatever district you're in, all of you. Reach out to the folks that are representing you and say, these are critical concerns we have and how are we going to address them, because that's what helps. And then trying to get the funding to do the studies that are necessary to be able to help you and help your colleagues help these kids.
Another question from the audience?
How about those Browns?
Good morning. Thank you again for speaking to us today. My name's Gotham Chibrolu, like Gotham. And yeah, founder of Believe, a digital health company that helps doctors, all the pediatricians, internal medicine over here, prevent opioid abuse and addiction. But really my main question was, you said that Ohio was the ground zero, and we see other states like West Virginia very hard hit. And my question to you, we hear a lot of answers, but why, in your perspective, was Ohio such a ground zero? Like, why wasn't it in any other state?
Boy, I wish I knew the exact answer, but I'll give you what I've looked at. I think a combination of unemployment, people wanting a way out, and unfortunately this was getting where they needed to go. The overdose, the idea that the opioid epidemic was getting bigger and bigger, and more people were getting involved in that. And then all of a sudden it was getting to like $1 a milligram, and 80 milligram OxyContin was $80 on the street. And then riding in right behind that was cheaper heroin with allegedly the same effects. And then in-road fentanyl right behind that. And fentanyl, that you know better than I do, but my understanding was like last stage cancer patients, helping them breathe. And so part of the problem was that you're relying on folks who are dealing street drugs to be putting together this mix, cutting the heroin with fentanyl, and then putting it out there. And just to give you an idea, one day when we were just starting our drug task force, court drug task force, and I'm walking back down the street in Chardon, Ohio, where I was a prosecutor. This lady's coming at me, and I know we just sentenced her son that morning for the third time he got caught with heroin. And I figured this is gonna go well, right? And the lady's like, "Thank you." I said, "Pardon?" She said, "Thank you. At least I know my son's alive." And I said, "Well, your son wasn't showing up on pawn sheets or burglaries, normal places you'd see kids who are addicted." And she said, "Oh no, by week, well-to-do family. They'd been on a vacation in Europe in the summer. He was going to Miami University. He started jaking when he was over there, admitted to his parents he had an issue. They came home, got him treatment, it hadn't worked, the usual cycle that they were going through. But he was working as an apprentice for an electrician. And so every weekend, he'd get his check, and then he'd buy. And he would do what he did last Sunday. But the trouble is, as we all know, today's mix wasn't last Sunday's mix, and he'd be overdosed. So 3 times you find your kid on the verge of death. We need to break that cycle. And so we've taken aggressive steps in working with the physicians about stop prescribing opioids, or at least not to the extent that they were with so many refills. And I know that they administered different ways of going about it and making urine tests for those who are on a sustained level of opioids for pain relief, that they have to be subjected to those. And if they have anything else in their urine, they're cut off from getting the opioids again. And then enlightening the pharmacists when they see the problems or see something that they see as a problem, to also go about reporting it. And the doctors have been very good about that. I mean, they had 4 years of med school, 4 years of residency, but during that time they had 4 hours in pain management. It wasn't necessarily conducive to explaining to them the addiction or the power of the addiction of opioids. So, all these steps are taking place, and so it's nice to see that the opioid and the overdose deaths are coming down. So I think we're having an impact, but I don't think by any means we're out of the woods.
Thank you. Thanks, Congressman, for joining us. Please thank the Congressman for joining us this morning. Hey, good stuff. Well done.
Appreciate it. Thanks for all you do.
Thank you, Congressman, and thank you to everyone who joined us today and our underwriter in DeVere. Have a wonderful rest of your day.